Good morning, everyone. On behalf of the University of Michigan Injury Prevention Center and our colleagues at MDHHS, I want to welcome you to the sixth in a series of discussions related to the opioid epidemic. Today, we're going to focus on pregnancy and patients with opiate use disorder and their treatment and management. We're going to have about 90 minutes, and we've built in time for question and answer. So please ask questions in the chat. They will be collated and we will answer them at the end. We are incredibly happy to have a fantastic panel of speakers who will share their knowledge and expertise with you today. Next slide, Taylor. First, we have Lori Burke. She is an OBGYN who is dual boarded in OB as well as in addiction medicine. She works at Connected Health with her colleague, Jennifer Hoffman, who is also dual boarded in OBGYN and addiction medicine. Alex Peahl is an assistant professor in OBGYN, and she's the co-director of Partnering for the Future Clinic. Doctors Burke and Hoffman do not have any disclosures. Dr. Peahl does receive grant funding from the NIH, FDA. She has some quality improvement funding from Blue Cross Blue Shield and gets funding from MDHHS. She's a consultant in the past for MRV, and she gets some research support as an advisor for PulseMore. I do not have any disclosures to share. So next slide. Thank you, Taylor. We have talked about this in previous webinars. If you have joined us in the past, providers can make an enormous difference related to bending the curve in the opioid epidemic. We make really important decisions regarding prescribing opioids in the first place. We can educate our patients, our communities, and policymakers about the benefits and harms of opioids. We can help those with opiate use disorder to find treatment. And with the abolishment of the X waiver, we all have a responsibility to do this as clinicians and prescribe medications for opiate use disorder. Last but not least, we can provide naloxone to at-risk patients and educate them about how to reduce their risks related to opioids as well as harm reduction principles. Next slide. In this presentation, as in other presentations, you're going to see us take a holistic approach to these issues. This is necessary to continue to bend the curve and reduce the risk of overdose and death in our communities. Next slide. As I said a moment ago, we are going to focus on pregnancy and opiate use disorder today. However, there's a lot of work to do, and there are a lot of other things and other aspects to this work that we have discussed previously and may continue to discuss in future webinars. So this is one in a series of conversations that we're having. Next slide, Taylor, please. So today we're going to talk a little bit about background and statistics. We're going to describe the evidence-based management of a pregnant patient with opiate use disorder. We're going to describe acute pain management of a pregnant patient on MOUD. Sorry, that's redundant with acute pain. We're going to touch on harm reduction and stigma reduction. We're going to briefly mention some legal issues, and we're going to invite your questions and answers. Please remember that in order to receive CME credits for attending this event, we need you to complete your evaluation, and this will be emailed to you at the end of the event. Next slide. As we prepared for this webinar, our speakers shared a lot of anecdotes and cases that have informed how they approach patients with opiate use disorder, and more specifically pregnant patients with opiate use disorder. These are a few snippets to get you thinking as well. Our speakers are going to talk about real life scenarios, de-identified of course, as they go through the content of this webinar. So the person who is stable on MOUD but requires acute pain management for one reason or another, the patient who discovers that they're pregnant, they're actively using fentanyl, and they come to your clinic looking for help and to discuss what they can do to enter recovery, the patient who's just delivered their child and the nurse raises a concern about the fact that they are on MOUD, is calling CPS appropriate? And then last but not least, the patient who's in active use and presents with a precipitous delivery. How do you approach that patient, engage in an effective conversation, and discuss harm reduction? Next slide. I'd like to invite Dr. Lori Burke to turn on her camera now. We are going to start with some epidemiology and statistics related to pregnancy and opiate use disorder. Thank you, Dr. Burke.
Thank you, Dr. Lozman. Good morning, everyone. Thank you for taking time out of your busy day to join us and discuss this vitally important topic that is near and dear to my heart. The statistic on this first slide reflects a time in my life when I was in college and medical school and residency and my early years as a practicing obstetrician. And the reality and why we're all here today is substance use in general is incredibly common. As you see in a survey that does use the term women, and I do want to take a moment and say, you'll notice many of the studies are somewhat dated, and that reflects a paucity of data that lacks in studying pregnant and birthing individuals in general, but this is intended to be inclusive of all birthing individuals, regardless of how individuals identify their gender. So I do want to take a moment and acknowledge that. And Taylor, can I have the next slide, please? So our most recent data from national surveys reflect how common substance use actually is. And I do want to take a moment and stress how early substance use can begin, which speaks to the risk factors for all individuals engaging in substance use. It's part of the reason, initially as an obstetrician gynecologist, Dr. Hoffman and I began our interest in addiction medicine. We were practicing obstetricians in an institution, and in a conference with our colleagues from the NICU, it was shared that they were experiencing an increased number of neonates demonstrating withdrawal symptoms, and when the records of the individuals that birthed those children, there was no record of any sort of screening for substance use being done. And what we know is in 2024 from a national survey, over 50% of individuals aged 12 and older reported using a substance in the past month. Now, this is inclusive of tobacco and alcohol, but I do want to emphasize that the risks of tobacco and alcohol certainly can be significant for birthing individuals. And about 17% of the national population qualifies as having a substance use disorder. Next slide, please. There are gaps in people accessing appropriate treatment for various substance use disorders. For birthing individuals specifically, or people who identify as women, they are a third of the people living with substance use disorders. Unfortunately, they only represent about a fifth of the population in treatment. This was striking to me as I came into the work of addiction medicine, and it still is common today in 2025 that it is far easier to find treatment for a male patient compared to a female patient. And when we talk about individuals who identify in the more minority gender groups, treatment that aligns with being appropriate for their identity is also can be a challenge. It is also important to appreciate that polysubstance use is more of the rule than the exception. It is, and sometimes patients do not realize that they are using various substances, and that is due to their substances that they believe they're using either entirely not being the substance they think they're using, or it being cut with additional additives. And we will talk more at the end of this webinar about the specific barriers to treatment, but we have to be cognizant of the fact that although it's 2025, we still exist in a culture that is heavily influenced by traditional gender roles. And for birthing individuals, they often fall into the role of caregiver. And there is a great deal of societal stigma that I would argue has higher stakes and higher rates of criminalization, and is a great reason that in patients I have had the pleasure of speaking with has a lot to do with why birthing individuals either don't seek prenatal care at all or fail to disclose their substance use. Next slide, please. This is older data, but reflects that in pregnancy, opioids are prescribed. And I'm not showing this statistic to say that opioid prescribing in pregnancy is wrong or inappropriate. There are certainly times where it is perfectly appropriate to prescribe a short course of opioids, and I think Dr. Hoffman will share some information about that when managing acute pain in pregnancy. However, of women who have used opioids, about 20% report misuse of the opioids. And this is reflected not only in data we have from birthing individuals, but also from when we look at studies that divided the population as male versus female, the reasons for substance use in female populations often have to do with more behavioral relief seeking, such as sleep, relief of stress, depression, and sometimes pain management. Next slide, please. It is vitally important that we also recognize that transitions in one's life are a particularly risky time as it relates to risk of overdose death. What we experience as clinicians every day in our practice is we see patients that are coming out of an incarcerated setting, leaving a residential rehab, or seeking care in their substance use disorder for the first time. What we know is overdose risks increase with large transitions in one's life. And this is reflected in a study that was published in 2024 that showed that coinciding with our increased rates of maternal morbidity and mortality are rising rates of overdose death in postpartum patients or during pregnancy. You see, I like the Venn diagram here that kind of graphically represents what that number looked like in 2018 and how it expanded in 2021. So being cognizant of this is everybody's responsibility who interacts with birthing individuals who we identify as having an opioid use disorder or really any substance use disorder. Next slide, please. So concepts specific to birthing individuals or in female populations is in the addiction medicine world what we call the telescoping effect. So accelerated course to what is initiation of substance use to meeting the criteria of what we call a substance use disorder. In women, the timeline from initiation of use to developing a substance use disorder is shorter. In addition, the duration of time from initiation of substance use to chronic medical condition worsened by substance use is also shortened for female populations. The concept of high stakes criminalization. This relates back to when I was speaking to the differences in access to treatment for male populations versus female populations. It is, and this is from my own experience, but in our practice, we treat people of all genders with substance use disorders, and by far and away, male patients and non-birthing individuals are much more readily accepting of the concept of leaving home, going away to a detox center, and transitioning to a residential rehab program if needed. Whereas a birthing individual or somebody who is in your traditional female gender role often expresses other responsibilities that may be holding them back. It's not that they don't want the treatment. It's, can I take my children with me? Who will get the children to school? Who's going to prepare their meals? Who's going to handle the transportation to my family? And we have very few treatment centers where birthing individuals are able to remain in their parent-child dyads and get simultaneous help with childcare and child rearing responsibilities, as well as treatment for their substance use disorders. So this then transitions easily to a discussion regarding gender responsive addiction care, which links in a coming slide, we talk about the biopsychosocial model of addiction. In addition, the research is very clear that rates of unintended pregnancy and rates of sexually transmitted infections are much higher in female populations engaged in substance use, which links easily to the practice of obstetrics and gynecology or primary care, where coordinating this type of care within a single setting for patients that may have transportation issues, providing increased access to these additional services is vitally important. Next slide, please. So this graphic is one of my favorites, and it talks about everything that we must consider when providing appropriate multimodal treatment for a patient's substance use disorder. We're going to talk a lot about medications today in treating opioid use disorder, but substance use obviously does not occur in isolation. There are pressures from society. There are high rates of co-occurring mental illness or substance-induced psychiatric symptoms. In addition, biology and genetics are at play. Genes have been identified that demonstrate for neonates, showing that they can have increased risk to develop a concept we know as neonatal opioid withdrawal syndrome, or NOWS, which will be talked about later in this webinar. In addition, and I've already spoken to this, is the systems in which all of everything we do exists, criminalization of drug use, and women in pregnancy specifically feeling that they cannot disclose their substance use for risk of being reported to legal authorities and punitive consequences of their substance use. Next slide, please. This is one of my favorite topics. It centers around simply talking to patients. Addiction as a whole and substance use is a chronic disease, And it is the responsibility of all members involved in any single person's care to ask patients about their substance use. We, as clinicians, often exist using electronic health systems that are great data banks of information for information sharing. However, on the consequence of those things is we often use templates or questionnaires to kind of increase our flow and efficiency in our clinical practices. These types of questionnaires and auto-populated data, I would argue, fail our patients sometimes. It's easy enough for a patient who just wants to check the box of getting their prenatal care and try to make this as quick as possible to check no to the questions about substance use. In addition, if a patient has been part of a health system and presented 10 years ago, and at that time was engaging in illicit opioid use, that may be in their medical record. And then that can routinely continue to get pulled into social history or substance use history. And we could be 5 years later and that patient may have achieved sobriety, and that is still getting carried forward. Although the history is significant, it should be qualified as opioid use disorder in remission. My favorite screener, especially in birthing individuals, is the 4 Ps. So it's 4 simple questions related to, in your pregnancy, have you had any problems with substance use? In the past, have you ever had any problems with substance use or feeling as if you were addicted to a substance? And I generally will go further and say, such as nicotine, marijuana, alcohol, opioids that either have been prescribed or that you purchased illicitly or obtained from other people. Similarly, you can proceed in those asking of those questions to ask about their partner and their parents, which goes back to the point that substance use does not happen often in isolation. And for many patients, there's a long family history of substance use disorders. Many of us who work in clinical settings are familiar with urine drug testing or blood serum toxicology testing. But I think it's important to be very clear with how these tests work in the setting in which you are working. Many of us are familiar with urine testing that gets done right in the clinic, where they quote unquote dip the urine with kind of a litmus paper to get an idea of what substances are in the urine. Those are screening tests. Those are not confirmatory tests. In addition, various screening tests screen for various substances. It is also important that you review with patients, in my opinion, that you're ordering these tests and why you're ordering the test, whether it's a routine that your practice does on all patients, or if there's a specific reason, such as they're appearing to have a altered mental state, or they're having vital signs that maybe reflect exposure to a substance. This makes the conversation much more respectful and easier when you're reviewing those results with a patient. Next slide, please. In addition to the validated questionnaires, I've developed some simple questions that I routinely ask my patients. Do you use any substances? My favorite question when I'm admitting a patient to the hospital is, while you're here, are there any substances you use that you will experience withdrawal or problems if you don't have access to while you're in the hospital? Asking about nicotine use and including cigarettes, vaping, nicotine pouches. Asking about alcohol, asking about marijuana, because simply saying, do you use any drugs or alcohol, just is not specific enough in our culture now, where there is a high level of acceptance of various substance use. There is this misconception that just because a substance is legal, it's safe for somebody to use, and your doctor won't have anything to say about it or advice to offer, which, as we all know, is not the case. Next slide, please. So here, and we apologize for how small the font is, but the questions you see on the left really are the DSM-5 criteria for diagnosing a substance use disorder, and specifically opioid use disorder. The easiest way to remember it for me is the concept of the 4 C's. Do you crave a substance? Do you feel that you have lost control over your use of the substance? Is your use compulsive? And do you continue to use an opioid despite consequences, whether those consequences are physical consequences, such as intoxication or opioid withdrawal, and negative consequences to your interactions with important people in your life or consequences at work. When you look at these criteria, if a patient, you can diagnose an opioid use disorder as being mild, moderate, or severe, and there are different qualifiers when you're assigning specific diagnoses to a patient's opioid use disorder. Next slide, please. So when you have been privileged enough that a patient has shared with you that they are pregnant and they are in fact using substances, it is important to take a very non-judgmental, matter-of-fact approach to ask them about their substance use. I generally start with, are you interested in discontinuing your use while you're pregnant? Most of us would assume a patient would say yes. And I will tell you that some patients will say no. If a patient says no, we don't simply throw up our arms and leave the room and not partner with our patients. This is where harm reduction is important. And I'm sure in your previous series of the webinar, you've talked a lot about harm reduction, but reviewing with the patients safer ways to use and helping them have access to supplies for any wound care if they're using intravenously, for needle exchanges, things like that. In addition, it's a wonderful time to discuss various treatment options. Treatment for opioid use disorder does not require attending mutual support meetings like Narcotics Anonymous, or getting a sponsor, or getting a peer recovery coach. But for some patients, that's vitally important. Some patients prefer individual psychotherapy. And this is important when we talk about taking a trauma-informed approach. As we know, and will be discussed later on in the webinar, there's a large degree of overlap of mental illness and trauma experiences in the substance-using populations. There are also medications for opioid use disorder, which will be the focus of the next section of our webinar. Obtaining medication for opioid use disorder does not require that a patient attends psychotherapy. In addition, the American Society of Addiction Medicine, or ASAM, has published various levels of care, extending from beginning at a patient being pre-contemplative about suspending their substance use, all the way up to being in a hospital for their detoxification and beginning of their treatment. Diving into those details is beyond the scope of this webinar. And what I'd like to say is, in general, for me, I support a patient having aspects of all of those things with therapy, mutual support groups, and medications. But what I tell all of my patients is what works the best is the component that you believe in and that will function best in your busy life. Next slide, please. There are well-known risks to chronic opioid use in pregnancy, and those are outlined here with these graphics. Overall increase in all maternal mortality, increased risk of preterm birth, stillbirth, low birth weight, respiratory problems for both mom and neonate, and feeding problems in the neonate. Next slide, please. So I'd like to invite my partner in clinical practice, Dr. Jennifer Hoffman, to join us on this webinar today, and she will be discussing opioid use disorder and medications for opioid use disorder in the pregnant patient. Dr. Hoffman.
Thank you. Lori Burke is my partner at Connected Health, and we met working as OBGYN doctors, and then we became board certified in addiction medicine and opened Connected Health. And here at Connected Health, we have the approach to substance use disorder that SUD is a chronic disease, just the same as any other chronic disease like hypertension or diabetes. And the treatments for those things are multifactorial, as Dr. Burke just pointed out, including behavioral treatments such as therapy, as well as the same as diet and exercise is a treatment for hypertension. Today, we will also talk about the medications that we use for the treatment of opioid use disorder. And before I begin, we are passionate about stigma and eliminating stigma for this patient population. And so I will present a hypothetical case. So I would like everyone attending to imagine that whatever your role is, whether you're a primary care physician or a nurse or a social worker or whatever your job is, at your job, you have a student working with you, and you've sent them in to see the next client. And they have been in there for a really long time and have bonded with the client. And they come out and present to you that the client is newly pregnant, maybe 8 weeks along by their last menstrual period, and actively using heroin, which around here is all fentanyl, intravenously, and they would like treatment for that. And to illustrate my point, I want you to, before you open the door, to go in the room, to form a picture of what that person looks like and how that visit is going to go, and any feelings that you have in your body before you walk in the room. And all of that is stigma. And then just to illustrate the point, if that same student came out and said that the next client is 8 weeks pregnant and has poorly controlled diabetes, how does that person look? And how is it different than the picture that you formed in your mind before you walked in the room? So that's something that I'd like to carry through this next section. And of course, Dr. Peahl's section about our treatment options, because we approach treatment through a chronic disease model. Next slide. So again, the basic overview we've just gone over, that the definition, the DSM definition of opioid use disorder is simplified into the 4 C's, and the treatment that we use in addiction medicine addresses the issues related to cravings, withdrawal symptoms, and preventing patients from returning to use. And there are currently 3 medications that are FDA approved for the treatment of opioid use disorder, and I will go over each of them briefly and how we use them in pregnancy. Buprenorphine, methadone, and naltrexone. Next slide. So I included this information about detox in pregnancy because here at Connected Health, we are still getting some referrals and new patients who are telling us that they have been stable on their MOUD, and because they are newly pregnant, it was recommended to them to stop it due to pregnancy. And this is not recommended. So I would like to focus on that for a couple of slides. And this is established in the literature that going off MOUD does not improve outcomes. In fact, detoxification, whether at home or in the hospital, has a high risk of return to use and also for preterm labor and abruption and problems with the pregnancy. So it is commonly accepted that continuing a patient who is stable on their MOUD is the gold standard in pregnancy and improves compliance and decrease neonatal withdrawal. Next slide. Medically supervised withdrawal is like detox in the hospital. I think that there is only one center that is actively attempting this in Tennessee. But the return to use rate is still approaching 90%. And this means giving patients a methadone taper during pregnancy with the goal of eliminating the use of illicit opioids. And it requires an inpatient hospital stay. And the way that healthcare is in America right now, this is not feasible, really. Would we consider it for a determined patient? Maybe, but it's nothing we've ever seen. Next slide. So for the 3 medications that are approved for treatment, I'll start with methadone. Methadone is a full opioid receptor agonist. And the way I explain that to patients is that it's like a key that fits in a lock and turns your car on. So it fully fits into the receptor and activates it. And in that way, methadone and OxyContin and heroin and fentanyl are all the same. They are mu opioid receptor agonists. The difference between all of those things is how long it sits in the receptor. So methadone has a long half-life and sits in the receptor longer than fentanyl, which sits in the receptor for only an hour. So that's why heroin and fentanyl have a higher high and a lower low, meaning more withdrawal symptoms. But methadone needs to be administered every day and is highly regulated because at its steady state, once it's been reached after about 5 half-lives or 5 days, there is no high or low. It just sits on the receptor all of the time, turning it on like your car. So it is slowly and safely increased once or twice a week, focusing on withdrawal symptoms and cravings for illicit opioids. Because it is a full receptor agonist, we can build tolerance to it the same as we do to other opioids, and there is overdose potential. And for that reason, it is highly regulated and only available at centers that have been licensed to dispense methadone. Pregnant patients often, because of pregnancy metabolism, require dose increases, not because of withdrawal symptoms and cravings that are more in pregnancy, but because of the protein binding of pregnancy, and also often require 2 doses a day instead of 1. And because of the availability of dispense hours at methadone facilities, usually that means that pregnant people have to take their dose at the methadone facility and take their other dose for the day home. The side effect of methadone is prolonged QT, especially if there are other QT prolonging medications on board, like Zofran, for example, and this needs to be monitored. Methadone is highly genetically metabolized. The reason I mention this is because often we talk to providers who say, wow, that patient is on a really high methadone dose. And what we say is we found and learned that there is a high genetic variability to the metabolism of opioids, methadone in particular. And so what works for one person may not work for another, regardless of what their body mass is, or how tall they are, or how pregnant they are. In addition, methadone was invented and released in the 1970s when heroin was still heroin, and there's almost none of that left in the heroin supply right now. It's fentanyl, which is stronger, and often higher methadone doses are required for the cravings and withdrawal symptoms associated with that. Next slide. The next medication approved for treatment of opioid use disorder is buprenorphine. And the way I describe this to patients, because it is a partial opioid receptor agonist and a partial antagonist, is that it's like a key that doesn't quite fit in the lock, and it only partially turns your car on, like just the radio and the lights. But it also gets in the way of any other keys getting in the lock. And that's how it works. And that's important for patients to understand, because it is the reason that buprenorphine is safe and not as highly regulated as methadone, because there is very little overdose potential because of its partial agonist and partial antagonist effect. Buprenorphine has what's called a ceiling effect, which means that if patients overuse their buprenorphine, they are unlikely to have intoxication or overdose. And that would only happen in someone who is opioid naive. And that's why it can be prescribed and picked up from any pharmacy. When we initially start patients on buprenorphine, we give 2 milligrams, which comes in a film or tablet that is dissolved under the tongue, every 2 hours until the withdrawal symptoms are better. And this is often done in emergency departments. The target dose is 8 to 32 milligrams per day. And Suboxone or Subutex are common brand names for buprenorphine containing products. And both of them are safe during pregnancy, There is another common misconception that Suboxone, because it contains both buprenorphine and naloxone, is not safe during pregnancy. But the naloxone portion of the Suboxone formulation is really only active if the formulation is melted and injected intravenously, and there is very little Narcan effect from the Suboxone when it's appropriately used sublingually or buccally. And so this is also a common misconception among patients. Sometimes patients believe that the naloxone is what causes precipitated withdrawal if it is given too close to a recent full opioid agonist like heroin or fentanyl, but it's actually the buprenorphine that binds stronger to the opioid receptor and blocks the full opioid from binding to the receptor. So if patients have experience with taking Suboxone illicitly or from a friend or bought on the street and having had withdrawal symptoms because it was taken in approximation to a full opioid agonist, it wasn't the naloxone that caused it, it was the buprenorphine. Next slide, please. And then the third medication that is approved for opioid use disorder is naltrexone, which is a full opioid receptor antagonist. And this is used for people in recovery who want to not return to opioid use. It is not very well studied in pregnancy and probably will not be, because as I describe this to patients, it's a full blocker of the lock in your car, like putting super glue in the lock. So nothing can turn your car on, not even the lights or the radio. And because of that, it is very hard to treat someone for pain if they have an unscheduled accident or injury when they're using naltrexone. And because pregnant people plan to eventually not be pregnant anymore, and they will have labor and potentially surgery, it is not recommended to have a full opioid antagonist on board because it makes it difficult to treat someone for pain. Next slide. Dr. Burke and I can't believe that this mother study is 15 years old already, but this was the maternal opioid treatment human experimental research, or MOTHER trial, which originally studied buprenorphine to see if it was inferior or not inferior to the gold standard of methadone during pregnancy. Next slide. And in fact, it found that buprenorphine was equally safe and well tolerated and not inferior to the gold standard of using methadone as MOUD, and therefore was an acceptable treatment for pregnant people. But it went on to find some other interesting conclusions. Next slide. They documented that there was a greater retention in treatment for the patients who received buprenorphine compared to methadone. And interestingly, the neonates required less morphine for neonatal opioid withdrawal syndrome, only 1 versus 10 milligrams. And the neonates had a shorter hospital stay with buprenorphine and less time in the hospital. And so this is often quoted to patients, but we still use buprenorphine or methadone for opioid use disorder in pregnancy. It's whatever works best for the patient. Next slide. So when it comes to actually following a patient with opioid use disorder throughout pregnancy, we do the usual prenatal care, which includes evaluation and management of all of their co-occurring behavioral and medical conditions, and evaluation of the social situation, who lives with you at home. Are you safe there? Are you at risk for violence, and screen for sexually transmitted diseases the same as we do for everyone. And the extra amount of prenatal care for patients with OUD include a couple more ultrasounds to monitor fetal growth, and some antenatal testing, including non-stress tests in the third trimester to monitor fetal health, and then close monitoring of the fetal biophysical profile. And this is after 32 weeks. And those are really the only extra things about prenatal care, in addition to the MOUD. Next slide. One of the things that we talk to patients about during their prenatal care is planning for delivery. And one of those things is about pain management during labor, or during scheduled cesarean, depending. And so for either one of those things, we recommend regional analgesia, so an epidural for labor, or spinal analgesia for cesarean. And the reason for that is because there is a very effective neuroblockade in both opioid naive and patients with opioid use disorder that is totally not dependent on previous use. And we also have used tap blocks, which is analgesia of the abdominal fascial wall for planned surgery. And we continue the patient's MOUD throughout. So a common misconception that we have heard is either that a patient who plans surgery, it either needs to stop their MOUD so that they can receive opioids for pain, or that they would only receive their MOUD and no opioids for pain. And both of these things are incorrect. So the way we describe it to patients is your MOUD is just your baseline. It's what you take for OUD to prevent cravings and withdrawal symptoms. And then any medication that we use for pain is on top of that and still effective. And so this is true if your patient needs to have dental work done on MOUD, or if they need to have a baby. Of course, I'm old enough to remember that years ago, we used to give everyone the same 30 Norco after a cesarean. And since then, of course, we have excellent studies that show that patients were not using those, that they were also not adequately disposed of. And now instead we look at what is actually used in the hospital, and we prescribe an appropriate amount for what was used and to last for no more than 3 days at home. Next slide. And then the postpartum period is probably the most important, but unfortunately is the most lacking in our healthcare system right now, because for the longest time, patients who were underinsured would often lose their insurance once they aren't pregnant anymore. And this is a really high risk time period for patients to return to illicit use, just because if you've ever had a baby, it's a really stressful time. And also, patients' bodies are stressed because they're not sleeping and they have these new responsibilities. So it's really the time that we would like to see patients more often, but unfortunately, we are not always able to do that. And Breastfeeding in patients with opioid use disorder is recommended, and patients on MOUD are recommended to breastfeed, and it is not dose dependent. And rooming in and swaddling is all recommended in the postpartum period. Next slide. So briefly, neonatal opioid withdrawal syndrome used to be called NAS, or neonatal abstinence syndrome. And they changed the name because, newborns are not abstinent of opioids. They don't choose to use them or not. And so this is very important. But the amount of methadone or buprenorphine that a patient takes for MOUD is not related at all to the amount of neonatal opioid withdrawal that the neonate will have. And that is well studied. So weaning down a dose does not matter at all. So a patient with a low methadone dose or a high buprenorphine dose may or may not have a neonate that needs to stay 1 or 4 more days in the hospital. It actually is not related at all. It is identified through a scoring system that used to be called Finnegan, and now has been simplified and spreading across neonatal ICUs across the country, called Eat, Sleep, Console, which is a scoring system related to how easy it is for babies to be consoled or fall asleep or eat. And that is the measure of their neonatal withdrawal. Next slide. So in summary, buprenorphine and methadone are used and safe and effective for opioid use disorder during pregnancy. There is some additional monitoring that needs to be done during the prenatal care period. Detoxification is not recommended, and the dose of MOUD is not related to the amount of withdrawal that the neonate will have. And now it is my pleasure to introduce Dr. Alex Peahl, who is nationally recognized in being an expert on maternity care innovations and the amount of opioid prescribing to pregnant individuals. Dr. Peahl.
Thank you so much, Dr. Hoffman. It is so wonderful to join this group today and to share the next part of our presentation, which is about stigma and harm reduction for birthing people with opioid and substance use disorder. On the next slide, I would like to introduce you to one of my patients. This is an example combined from many experiences. So this patient was a 29-year-old woman. She was a G3. She'd had 3 prior pregnancies and 1 prior birth, and she came to our clinic at 24 weeks. She was well into her 2nd trimester and was in active use with fentanyl, as well as cannabis products and tobacco. And her substance use disorder had started about 8 years prior with her first birth. At that point, she had received an opioid prescription after a routine vaginal birth to manage pain. Well, she didn't have much pain after the first few days returning home. She did find that that prescription really helped with her postpartum anxiety. She sought a refill from her obstetrician gynecologist, and then additional refills from urgent care, and ultimately found that she was utilizing the medication to avoid withdrawal symptoms. When she could no longer receive any refills through her OB, her primary care doctor, or other urgent care locations, she started to seek out non-prescribed opioids, ultimately using IV heroin. And as Dr. Hoffman alluded to, over time that became IV fentanyl as the drug supply transitioned. Her mom assumed custody of her baby, and she struggled over the next 8 years with periods of abstinence. At times, she was able to move into recovery. She utilized methadone at one point, but found that she could not continue to go to the clinic daily and maintain her job. She attempted a course of buprenorphine, but was unable to navigate that transition, found that the withdrawal period leading into her buprenorphine prescription was very uncomfortable, and she did not want to experience that again. When she became pregnant, she wanted things to be different. She was very motivated to enter recovery. She found our clinic online after several attempts to enter treatment. And in her first visit with us, she shared, "No one would take care of me. They just kept saying, 'How could you do this to your baby?' But they wouldn't help." We started our initial visits with her hearing her story. We diagnosed her chronic conditions, including hepatitis C, and our psychiatry team saw her to help diagnose her depression and anxiety. She received wraparound services in our clinic, obstetric and prenatal care, psychiatric care, counseling with our in-house social worker and behavioral health consultant, and even physical therapy for her pregnancy-associated back pain. It took us a couple of visits to even broach the subject of medication for opioid use disorder. While we brought it up as an option in the beginning, she didn't feel prepared for that part of her journey. She and her partner really had concerns about just replacing one drug with another, and she was concerned about the need to go through withdrawal to initiate the medication. But after building trust in a relationship, she decided to give the buprenorphine a try. She tried a microinduction on the outpatient side. Unfortunately, insurance would not cover her medication once we worked our way up to the 8 milligrams 3 times a day dosing. And at that point, she presented for an inpatient stay to complete her microinduction protocol, which she did successfully. She was able to maintain recovery throughout her pregnancy, have a term birth, and we followed patients up to 1 year afterwards. She and her healthy baby boy come see us frequently in clinic, and she's been recovering well and enjoying her time with her children, who now both live with her. Next slide. In spite of the efficacy of medication for opioid use disorder and the clear benefits for birthing people, the majority of patients in the United States are still not able to access it. This claims-based study, shown on this slide, found that people with commercial insurance in the United States did not receive medication for opioid use disorder in the rates that we would hope. In fact, only 1 in 3 received buprenorphine. And state criminalization of opioid and substance use in pregnancy was associated with lower utilization of this medication, 23% in states with criminalization versus 43% in states that did not have these kinds of legal restrictions. Next slide. Over the past 2 decades, we've seen increases in the prevalence of opioid and other substance use disorder, as well as mental health complications and suicidality in these populations. So while substance use disorders are becoming more common, complex, and deadly, access to care is being eroded. This serves as a direct barrier to recovery, pushing people into the criminal justice system rather than medical services. Next slide. To go one step deeper, these challenges are unique to the United States. According to Pregnancy Justice, a nonprofit that seeks to document instances of pregnancy criminalization, the majority of criminal cases brought against birthing people from 2006 to 2022 have occurred in states with legislation that defines child abuse as including fetuses, fertilized eggs, and embryos. In the overwhelming majority of these cases, over 1,300 or 9 in 10 of them are based in substance use allegations. As I mentioned, this kind of legislation exists in 25 states and Washington, D.C., with 33 states having a variety of punitive policies on record. And additional laws supporting the notion of fetal personhood related to abortion further legitimize this criminalization, limiting access to diagnosis and treatment. Next slide. In fact, the current laws that require reporting by social workers, educators, and medical professionals create a terrifying environment for birthing people where the very people meant to help them, their healthcare professionals and social services providers, can take away what they care about most, their children. And I think this quote from Pregnancy Justice summarizes it best. Contrary to claims that arresting and prosecuting pregnant people will encourage them to desist from substance use and thus improve maternal and fetal health, fears of detection and punishment present a significant barrier to care, causing some people to delay or avoid prenatal care altogether. And this creates a health risk. Often when patients come to me for their pregnancy care, they are scared. They are worried that I'm going to take a test of their urine without notifying them, and that then that test will be used against them in criminal cases. For that reason, we really focus on trust and relationship building, and this has to be the cornerstone of care for birthing people with this chronic condition. Next slide. When considering the context that patients with opioid and substance use disorder come to us with, it's also important to note that trauma and care barriers are prevalent and impactful. 80% is the number to remember. 80% of women seeking treatment for addiction report a history of physical and sexual assault. 80% report trauma. 80% report a comorbid mental health condition. And 80% of clinical outcomes are driven by social factors. There is a lot happening in our patients' lives that affects their ability to show up for care and engage in our services. Next slide. With all of this context, perhaps it is not surprising that fear is the number one reason for not seeking prenatal care in birthing people using substances. And it's therefore critical to carefully consider how patients with opioid and substance use disorder come to us in the healthcare system and how we can best support their complex needs. So when we think about care for this population, the how is equally important to the critical what that Drs. Hoffman and Burke just shared with us. And so I'll share with you today 4 principles for providing patient-centered trauma-informed care and moving into the day-to-day in caring for this important population. Those 4 principles are on the next slide, and they include our words matter, bringing a trauma-informed approach, elevating principles of harm reduction, and carefully attending to social drivers of health. On the next slide, we'll start with language. Words matter. How we talk influences how we view our patients and how they view themselves. This is a space that is rapidly evolving, and so I encourage my team to point out areas where my language may not be best supporting my patients, and we do the same all together. Ideally, language is person first, talking about a person with substance use disorder rather than an addict. In pregnancy, we have increasingly moved towards gender-neutral language, recognizing the variety of individuals who can come to us with pregnancy. We try and use language that reflects partnership, helping a patient to start medication for opioid use disorder rather than starting the patient on medication. And this is a big switch for me as a healthcare professional and very different from how I was trained in medical school. We also try and reduce stigmatizing language, talking about a patient receiving medication for opioid use disorder rather than being on MOUD. And we also try and put the onus on us as the healthcare system, talking about populations that are hardly reached rather than saying that they're hard to reach, which puts the blame on them. There are a few additional examples on the next slide. And here you can see some language from the harm reduction toolkit and different words that we can use to help really promote that person-first language. I have found that it is incredibly important to find the positivity and highlight small wins and stories of success and recovery. I think this is really important with our colleagues, our friends, and our family. Often when people learn that I care for birthing people with opioid use disorder, they respond with, "Wow, I don't know how you can do that. That must be so hard." And I've really tried to shift that narrative and share the resilience and the strength of our patients, the great joy that it is to support them, and the victories that individuals have in their journey to recovery. On the next slide, you see some examples of messages that are often shared with my patients when they come through the emergency room, they're receiving an ultrasound or a scan at a facility. And these words can be incredibly harmful and alienate our patients from the healthcare system, talking about their roles as parents or as individuals. And I think that some of these messages really reflect that goal of partnership. I know you love your children. What can we do to help you? Or what was it like when you lost your child? Recognizing and meeting these people with empathy. On the next slide, I just want to briefly talk about principle 2, and that is trauma-informed care. Given the high rates of trauma faced by our patients, including trauma through the healthcare system, a trauma-informed approach can really help our patients to feel safe and cared for in the clinical environment. And trauma-informed care could be a lecture in and of itself. I'll just try and hit some quick principles. This approach realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in not only clients and families, but also ourselves as healthcare providers. It allows us to respond with integrating knowledge of trauma into policy and resisting re-traumatization. Those 4 key steps are on the next slide. And this includes realizing trauma is widespread, making sure staff are trained, and that we highlight any areas of care that may be re-traumatizing, such as blood draws or pelvic exams. Recognizing symptoms of trauma in patients is critical, not only using formal screening methods like screening for PTSD and adverse childhood experiences, but also helping our staff to recognize that information is not a privilege and that we need to earn the chance to hear patients' stories. Responding to trauma involves incorporating trauma-informed care into policy, procedures, and practices. This can include things like having patients remain dressed in their first visit rather than asking them to ungown, or holding off on collecting urine samples until the patient and the provider have had a chance to have a discussion. And then finally, resisting re-traumatizing or avoiding perpetuating trauma. Incorporating patients into care plans, understanding what events may be triggering for them, identifying those concerns in advance, and acknowledging the great resilience that comes with returning to our clinic can all help in this space. On the next slide, I want to elevate some of the points about harm reduction that Drs. Burke and Hoffman have alluded to in their presentation so far. Harm reduction is defined by the National Harm Reduction Coalition as a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. And it's also a movement for social justice built on a belief in and respect for the rights of people who use substances. Harm reduction, I think, is a shift for many of us who are medically trained. It shifts from getting people to do the right thing to getting people to come back safely. On the next slide, we have some examples of this. Harm reduction recognizes that recovery work is not all or nothing. As you can see here in the examples, there are many ways that patients can continue active use more safely. Making a plan for safety before using, reducing the risk of infection through clean needles, or continuing to engage in prenatal care while in active use. We talk through these possibilities with patients, meeting them wherever they are. On the next slide, we'll go over the 4th and final principle, and that is to address social drivers of health or barriers to care. It has been humbling for me as a clinician to recognize that what happens outside of the office and the hospital has a greater effect on health outcomes than any clinical care that I provide. Social drivers of health on the next slide are quite varied and include multiple domains from economic stability to education, healthcare, environment, and even psychological health. Social drivers affect people's ability to drive to their appointments, to miss work, to come in for services, even to take their buprenorphine if they need to be talking during their job. Recognizing all of these drivers is critical for making sure our patients are able to be healthy. On the next slide, I want to introduce you briefly to a slightly different framework for addressing social drivers. In routine care, often the patient comes, they have unmet social needs, which limit their care access, and we don't discover them until the poor outcomes occur, until patients have missed services or even had an adverse outcome like a preterm birth. On the next slide, you see a slightly different way of approaching this, and this is the framework recommended by the National Academy of Medicine. When a patient first presents for care, we assess for unmet social needs, and so then we know about them. And we're able to address them in two ways. One, providing assistance, and this is the traditional way we think about needs, providing someone with a ride voucher if they have transportation insecurity, connecting them with food delivery if they have inadequate nutrition. And that resolves the needs and can lead to better outcomes. But the other approach is one that's a bit more in our hands as healthcare professionals, and that is adjusting care to be more accessible. We can imagine that same patient who has transportation insecurity or challenges with employment and getting time off of work. Rather than requiring an in-person visit, we can move their care to virtual visits for those that don't require in-person services, maintaining that connection and helping them to access our care safely and in a way that meets their needs. Next slide. Caring for birthing people with opioid and substance use disorder is a team sport. I feel very fortunate to work with social workers, home visitors, partnerships with WIC and MIHP, peer recovery coaches, all of these different individuals who come together to wrap their arms around our patients. Not every patient needs support from all teams, but having that ability to build that support network is critical for helping folks to navigate all of the challenges that they face in accessing evidence-based services. Next slide. Combining all of these services together is also called comprehensive care. This includes medical care, mental health services, as well as social services to support patients, ideally co-located in one facility. Comprehensive care is evidence-based. It has been shown to improve continuation of care, patients' engagement with OUD services, maintenance of medication for opioid use disorder, and family cohesion after birth. It is effective because it provides care for the whole person with reduced barriers to entry for all services. I hope these principles help you in your care of birthing people with opioid and other substance use disorders. And now I'm excited to invite Drs. Burke and Hoffman back on screen to help with the next steps of our presentation. While they're coming back on screen, I think on our next slide, we just wanted to introduce you to some resources that are available in our state of Michigan. We know that sometimes starting care for birthing people with opioid and substance use disorders can feel like a big task, and you have lots of folks around the state who are here to help you. At the Partnering for the Future program, based in the University of Michigan, we have the ability to provide services for birthing people with opioid and substance use disorders, as well as chronic pain. We do both preconception consults and care up to a year postpartum. And we are able to primarily manage patients for their pregnancy, as well as provide consultation and co-management. And Drs. Hoffman and Burke have an excellent program as well that I'll turn it over to them to share.
Here at Connected Health, we see people of all genders, age 14 and older, with all substance use disorders and any other addiction problem. We also provide comprehensive gynecology services, and we are available for telehealth consultation during prenatal care, and we will be happy to forward our contact information to anyone who needs it.
We are also working with MDHHS on the We Treat Hep C initiative and ourselves and a nurse practitioner who works via a telehealth platform out of Connected Health are happy to see patients who are in need of hepatitis C treatment.
Doctors Burke, Hoffman, and Peahl, thank you so much for this fantastic presentation. We have one question, and that is related to one of the proposed cases that we had, which we didn't get to so far, related to the woman who's on MOUD and a nurse in the peripartum period comes up to one of you and asks about whether or not CPS needs to be called due to their understanding of who is a mandated reporter and what that entails. I invite whoever wants to speak first, how you would respond to that nurse, what education might you give them, and how might you approach that question?
I can start. This is one of two questions that our patients ask when they first present for care. One question for those who are on medication for opioid use disorder is this medication harming my baby? And the second is, will I be able to take my baby home? And so ideally, we're able to start addressing these questions as part of routine prenatal care. And this is, in fact, on our checklist of conversations to have with our patients. I have very intentionally positioned myself in our clinic as the person who is there for the pregnant patient. And so I always refer my patient to our social worker for a conversation about the potential for CPS involvement based on their individual history as well as their current substance use. We talk about urine toxicology testing as a method of demonstrating continuation of recovery. And we use shared decision-making and informed consent process around that tool. CPS involvement is complex. Substance use is just one part of that consideration. And so I have my social work team walk with patients through those considerations. And it can be really important to communicate that information to the inpatient team so that policy and not bias or stigma is driving those discussions with CPS.
Yeah, I echo everything Dr. Peahl just shared. And we're a very small private practice, so unfortunately we don't have a social work team. That would be awesome to have. But the same questions come up here on a day-to-day basis when we are seeing patients. And I'm very matter of fact with them. And the answer is it really depends. And I encourage patients and always provide praise that you are addressing your disease of addiction and you are here getting help and reviewing the concepts of what CPS is there to do. It's important to understand what is that individual patient's history. Have there been prior CPS involvement in their case? Who are they living with? Are people in the home that are using substances? I'm always very clear, because you have addiction, because you use substances, that doesn't mean you don't love your child. That doesn't mean you are not a good parent, but it's about creating a safe, sober environment for that child to be reared in. So my response to a nurse in that scenario will be, well, what is the concern specifically regarding this patient in this case? Being on MOUD in and of itself is not grounds to consult with CPS.
Thank you so much. Those responses, I think, are probably really critical for all of us to reflect on, as this is definitely a question that comes up. Lisa, do we have any other questions? It looks like we do not have any other questions right now. We are just about at time, so I'm going to go ahead and close this webinar. Thank you again to our panelists. I learned a lot listening to them today and then helping to put together the slides over the past few weeks. I hope that you learned a lot as well. If you find that there are questions that come up as you think through this material, please don't hesitate to put that in your evaluation, and we will feed it back to our panelists for their input. There was one question from attendee about whether or not we're going to be sharing these slides. As I mentioned in the beginning, when you fill out your evaluation, you will get a copy of the slides. In addition, we have recorded this presentation, and the link to the recording will be shared, and it will live on our website for people to refer back to as they see fit. With no further ado, thank you to Dr. Burke, Dr. Hoffman, and Dr. Peahl for taking time out of your incredibly busy schedules. Thank you for all the work that you do for our patients in our communities. We appreciate you so much. And to our audience, thank you so much for coming, listening, and engaging with us. We appreciate it so much. Without further ado, I hope for sunny skies today, since it's the end of September, and I wish you all well. Take care. Bye-bye.